Thank you to inviting me to speak about screening. The question was, is breast screening the right imaging for the right patient at the right time? Breast cancer is a public health problem. Breast cancer is the most common cancer in women. In France, we have 54,000 new cases per year. Breast cancer is also leading cause of cancer deaths in women. As you know, breast cancer meets the three conditions for organized screening: health frequency, sensitive tests well tolerated, it's mammography, and there is early diagnosis may allow better therapeutic outcome. So why screening? Because screening is based on the dogma that early detection reduces breast cancer mortality. But is it so easy? What is screening? You have a free population invited to pass a mammography. Here you have the French data, and mammography can detect 7.4 per 1,000 cases breast cancer. But you know that there is also false positive and mainly interval cancer, 9.5 per 1,000. Interval cancer is a cancer that emerges between that appears in 2 years following a negative mammographic screen. And interval cancer decreases the sensibility of the screening. Because this sensitivity and specificity of the screening is not optimal, there is for several years a controversy about breast screening. Controversy about effect on mortality, overdiagnosis, breast cancer induced by low-dose radiation exposure, and false positive, which have negative psychological impact and negative cost effectiveness. This controversy has scientific basis. The first to have fed this controversy is the Cochrane group. From the 8 historical screening study from 60s, they have regularly published review. This review going in the same direction. For 2,000 women screened, 1 life saved, and 200 false positive and 10 overdiagnosis. But from the same study, the International Agency for Research on Cancer groups concludes a benefit for screening of women from 50 to 69 years. So, more accurate screening is a relevant question. How to improve the risk-benefit ratio of screening? 3 possibilities: improve the test, improve the radiologist performance, improve the relevance of screening. Improve the test with MRI, Curl, in this prospective study, evaluate breast MRI imaging screening in a population with average risk. MRI is added to digital mammogram. The result of the study show a supplemental cancer detection rate for MRI imaging screening of 15 per mil cases. What is interesting is the breast cancer are high nuclear grade and no interval cancer are observed. But the limits of MRI screening are difficult access, the cost, and probably false positive, and also the doubt about pathogenesis of deposit gadolinium. What about tomosynthesis? Despite a different methodology, published results agree to show that tomosynthesis increases the cancer detection rate and the recall rate is the same or decrease. But there is no significant difference for interval breast cancer, and cancer screened by tomosynthesis alone are cancer with better prognosis than interval cancer. So the question is tomosynthesis in screening, overdiagnosis or better diagnosis? And what about the dose? Because today in Europe, mammography synthetic is not validated in screening. What about ultrasound? In France, we recommend ultrasound for dense breast type C or D from biorad. In this work, in this French work, ultrasound screened cancer are a little more than 2% of the global screening cancer. In this publication about ultrasound in dense breast, you see that ultrasound can detect additional cancer 4.4 per 1,000, but the predictive positive value is low and the local weight is high. Does ultrasound for dense breast change the contribution of tomosynthesis in squeezing? In this prospective multicentric comparative trial of adjunct screening tomosynthesis or ultrasound in women with mammography negative dense breasts, you see that ultrasound detects more breast cancer, it's here, than tomosynthesis. The question is tomosynthesis or ultrasound. Rafferty shows that tomosynthesis increases cancer detection rate for women both dense and non-dense breast tissue, but is not significantly in experimentally dense breasts. And as you know, ultrasound is better in very breast dense. But perhaps it's not a good question, tomosynthesis or ultrasound. Perhaps it's not for the same patient. The second way to accurate screening is improve the radiologist's performance. Double weighting improves the sensitivity of the program. It's better when it's double blind, but all the modality of double weighting improves the sensitivity. Here you have the French data. In France, we have double weighting without consensus. And for 2000 screening, we found about 15 breast cancer screening and 1 from the double weighting. But there is about 20 recall post double weighting. Artificial intelligence and deep learning. Je suis perdue. If we refer to PubMed, you see that artificial intelligence and deep learning are the subject of an exponential number of work in recent years. I show you two recent publications. Yala and the collaborator estimated they could reduce the reading by 20% without affecting sensitivity. In this second work, the authors evaluate the feasibility of using an intelligent interfacial system to pre-select likely normal mammograms. They show also that it could be reduce the reading workload without decrease the detection performance of radiology. This raises the question of the possible replacement of the second reader by an algorithm, intelligence artificial. Today, the third way is to improve screening is to offer individualized screening strategy based on the individual risk. There is two trials integrating breast density and polygenic risk score. SNPs, single nucleotide polymorphisms, are variations of a single base pair of the genome DNA compared to the other individuals of the same species. These variations are very frequent, and a polymorphism alone is not a very good predictor. of risk, but polymorphism score can identify risk in a relevant way. I present you the European trial, MyPEPS. 5 countries, and the aim is to propose screening at 85,000 women, 4 years follow-up, to harm the standard with randomization. And what is interesting in the second is the arm with risk stratified. The primary objective of MyPEPS is to show a non-inferiority of the stratified screening strategy in terms of incidence of breast cancer of stage 2 or higher. The interval between 2 screenings will be based on the calculation of the risk integrating density and SNPs. If for a low risk, under 1%, we propose to the patient one screening every 4 years. In the opposite, if for low risk, more than 6% is the same risk than BRCA patient, it's proposed an annual MRI until 16. And for the average risk, it depends. When it's low, under 1.66, it's screening every 2 years, and between 1.6 and 6%, mammography yearly. In conclusion, with screening the right imaging for the right patient at the right time, it's a good question. The answer will come from the development of the 3 axes: test performance, tomosynthesis and ultrasound, it's debate. Radiologist performance, probably with artificial intelligence, and personalized screening according to the risk. Thank you, and sorry for my English.